So thank you, Ed, and thank you to the Foundation for inviting me and allowing me to speak. So as Ed said, my name's Andrew. I'm a general thoracic surgeon, meaning I perform operations in the chest, but not heart surgery, and trained specifically for that task at Memorial Sloan Kettering and was lucky enough to come to Sinai to work and have been there for about a decade. I will say I have no disclosures. I don't have any financial arrangements with any companies. The one disclosure I will make is that, like many of you, I was a caregiver for a carcinoid patient and who received care at many of the institutions that are represented today and got world-class care at NYU, Memorial Sloan Kettering, and Sinai, sort of following me wherever I ended up. And so today is sort of an emotional day for me as well because I remember a lot of things that many of you are going through. So I share with you a lot of the questions and the need for answers, and that brings me to what are the goals of my talk about lung neuroendocrine tumors, because I know the vast majority of our audience is here for gastrointestinal, not for lung, but for the few people and many of whom that are here I may have operated on actually, and we've become like a small family. The goals of the talk are really to increase understanding of what lung neuroendocrine tumors are, and you may, in your passing in the community, encounter people who may ask you questions about this because they may know you have or are a family member of someone with a neuroendocrine tumor. They may just ask you off the cuff, hey, do you know anything about lung? I have a family member. So hopefully today you'll get some basic information that maybe you could help pass on. I will provide an overview, a very basic overview of the surgical treatment for pulmonary carcinoid tumors. And the real main goal of this is to alleviate a lot of the concerns and misunderstandings that are associated with a diagnosis of a pulmonary carcinoid. And the main reason is, and as my talk will go through, while we consider them lung cancers, they really are a very separate group and behave clinically in a very different way, and that all the fears and concerns that go with the diagnosis of a cancer, and especially a lung cancer, may not really be valid for primary pulmonary carcinoids. So lung nets, what are they? Neuroendocrine tumors arise from neuroendocrine cells throughout the body, and I stole that sentence from Ed Wolin, who published that in Chest a few years ago. 75% of them occur in the GI tract, right? So most people here are involved with a family member themselves who have a GI neuroendocrine tumor, but did you know that 20 to 25% of NETs occur in the lung and are primary neuroendocrine tumors of the lung? Now, primary lung neuroendocrine tumors, while they're 20 to 25% of all NETs, also represent about a quarter of all primary lung cancers. So it's a little bit of a different statistic. So 25% of diagnosed lung cancers actually fall into the neuroendocrine tumor category. That means that the cell of origin is a neuroendocrine cell that has the capacity to secrete neuroendocrine hormones. Lung nets are actually divided into 4 basic categories, and this is just based on their microscopic characteristics. They're the typical carcinoids, the atypical carcinoids, the large cell neuroendocrine cancers, which are more aggressive, and then the small cell lung cancers, which are the most aggressive. Small cell lung cancers probably make up the vast majority of lung nets. These tumors, while they're all sort of housed in the lung cancer group and housed in the neuroendocrine lung cancer group, they really have a wide spectrum of clinical behaviors and only share their microscopic characteristics and fundamental cell type of origin. They really just, in reality, behave very differently. So Bill Travis, who's one of the greatest pathologists I've ever worked with and one of the nicest people I've ever met, has been a real leader in categorizing lung neuroendocrine tumors and especially carcinoids, and there's a WHO classification that Dr. Wolin sort of already mentioned, and we have the low-grade tumors, which tend to be well-differentiated or intermediate differentiated tumors, meaning that they hold on to their basic characteristics of the cell type of origin. They're not so aggressive that they're losing their characteristics of where they came from. They tend to have what we say is an indolent growth pattern, meaning a very, very slow growth pattern without obvious invasion or metastasis. They sort of just grow where they started out and stay there. For the pulmonary carcinoids, the 2 groups are typical and atypical. Combined, those represent about 2% of all lung cancers that are diagnosed per year. So, and we'll show you the statistics, it's really not a large number of cases per year. But the neuroendocrine societies of both Europe and North America are unanimous in their decision that surgery really is the best and only curative treatment option available for primary lung carcinoids. The other lung nets, such as the high-grade or poorly differentiated tumors, are much more aggressive. LC-NEC tends to act more like a very aggressive lung cancer. We tend to see that associated with heavy smoking, and those are treated really like regular lung cancer. Small cell lung cancers are the most aggressive and are the vast minority of patients we'll ever operate on. And in my career, I've operated on maybe 5 to 10 people with small cell cancer, because at the time of diagnosis, it's usually more disseminated where surgery will not help. All lung nets, though, are considered malignant, meaning that they have the ability to invade and metastasize. And as we all know, every person is unique in where they are with this diagnosis. And this is one thing that we have to explain to people, is that while carcinoids tend not to be that dangerous and people do very well with them, they can invade and they can metastasize. How do we find people with lung carcinoids? Some people may have a chronic cough, and if Ed's cough doesn't go away soon, I'll have to evaluate him for carcinoid. Some people will have a recurrent pneumonia, and this may be a totally young, healthy person that keeps getting diagnosed with an upper respiratory infection, mainly because there's a propensity for these tumors to grow within the airway and block the airways, leading to pneumonias. Some people may cough blood. The medical term for that is hemoptysis, and so they may have persistent blood-tinged sputum that brings them to medical attention. Very rarely do we come to a diagnosis based on a paraneoplastic syndrome. I've actually never seen anybody come with a diagnosis of carcinoid due to a paraneoplastic syndrome. I would say that many people that we end up diagnosing with a pulmonary carcinoid, actually it was an incidental finding. So looking at statistics, in 2010, there were about 225,000 new lung cancer diagnoses in the United States. If 20 to 25% of those are neuroendocrine tumors, that means about 56,000 will be a neuroendocrine tumor, most of those probably being small cell. Since pulmonary carcinoids only represent at the most about 2% of lung cancers, that's around 4,500 cases per year. So it's not a huge number of patients. However, the incidence, meaning the number of people who are diagnosed each year, keeps increasing since the 1970s, and the most likely reason for that is that the advent of better technology in terms of imaging, which are CT scans, and the increased utilization of those CT scans. So now, if Ed's cough doesn't get any better, he will get a CAT scan, and we will find potentially a lung carcinoid that had nothing to do with his cough. So pulmonary carcinoid tumors, they're well to intermediately differentiated and indolent, 2%. The age range is about 40 to 60 years old, and they are not smoking related. So I really emphasize to the patients that come to me that this is not something that should engender any sense of guilt. It's whatever they did in their lifetime had nothing to do with them getting this tumor. The typical carcinoid group is the least aggressive, and that's a great thing. They're the majority of the carcinoids that are diagnosed per year. About 70% of the carcinoid tumors are typical. Only around 10% will present with spread to lymph nodes. So it just says that it's not a very aggressive tumor, although you will find plenty of exceptions to that rule. They can be located in the center of the lungs and in the airway, and even in the main airway, blocking off the complete lung on one side of the chest. Atypical carcinoids, which are more aggressive, they have more atypia, more mitotic activity, and more necrosis, things that Dr. Wolin was mentioning. Those are all signs that the cells are growing faster than the blood system allowing to feed the tumor. And they tend to be more peripheral in the lung, but they have a higher incidence of lymph node involvement at the time of diagnosis, up to 40%. The good news is that even if you have a typical or an atypical, and I'm not sure I know how to use this, I added this red line to the graph because that's a 5-year time point. The 5-year time point is what we normally use for standard lung cancer, and you can see on this graph that the time point goes all the way out to 10 years. So already we're following patients for a much longer period of time, meaning that they just do better. When you look at typical carcinoids, the top line shows those without lymph node disease, the lower line shows those with lymph node disease, and the survival is excellent in both groups, better obviously without lymph node disease, but still just superb survival at 10 years, upwards of 90%. So most people do very, very well with typical carcinoid tumors, even if it had a chance to spread. Atypical carcinoids, being more aggressive, have more of a split between those who have no nodal disease and those who do have nodal disease, mimicking more of an aggressive pattern that we would see with standard lung cancer. But the big difference, and what I'm trying to emphasize in this talk, is that when people come and they're afraid that they have lung cancer, we are not speaking about the typical lung cancer mortality rate of survival rate of 15% overall at 5 years. We are really dealing with a much better substrate. When you look at the effect of nodal disease in standard lung cancers, the addition of nodal disease here in the 2A, 2B, and 3A categories significantly drops the survival down from around 80% to the 30 to 50% range, and we do not see that similar effect with carcinoid tumors. How do we diagnose a carcinoid tumor? Usually someone will have a CT scan, which, as you can see, will pick up a peripheral lung nodule. We now have the ability to do image-guided needle biopsies most of the time to make that diagnosis. We can get dotatate PET scans, which Dr. Kosselu will talk about, very sensitive for picking up receptor-positive disease. We can check and see if lymph nodes in the center of the chest may be involved. We are fortunate that the emphasis in surgery nowadays is less and less invasive procedures, so more and more minimally invasive approaches. We can diagnose tumors in the airway and lymph nodes with an ultrasound-guided needle device called an EBUS TBNA. And I was looking for slides that would have cytopathology on it, so I'd like to thank Weston, actually, for putting the slides up here. Because when you look at it, this is exactly what my specimens look like. You'll see red staining normal cells and then very dense, darker cells in the middle that suggest malignancy. So thank you, Weston. What are our options for surgery? We can do a lobectomy where the anatomic lobe, meaning the airway, artery, and vein to that segment of the lobe is removed. We can do a wedge resection, which means a small piece of lung that's non-anatomic is removed. We can do a pneumonectomy, which we don't like to do because that removes a lot of healthy tissue, but sometimes we have to if it's a central tumor. Or we can do something called a segmentectomy, where it's further out in the lung, but we still take individual airways and blood vessels. Other exciting things that we get to do is that not only do we try to take less lung when we're doing anatomic resections, we also try to save lung when we have central tumors. So we're able to do things which are technically challenging, but a lot of fun, and that's recreating the airway either with something called a bronchoplasty or a sleeve lobectomy, where since the tumor is actually growing in the lining of the airway and through the cartilage of the airway, we actually have to cut away that part of the airway and then recreate that airway to reestablish flow of air and save the lung that's not involved with the tumor. Segmentectomies, there are many different segments in the lung that we can remove individually and save the vast majority of lung tissue. We're also able to do these operations now more and more minimally invasive, whether it's with a robot or standard VATS. And my mentor and colleague, Dr. Flores, who we came together from Memorial many years ago, established VATS as a valid operation. We used to have to do standard thoracotomies with big incisions and big retractors, but we're now able to use small incisions, about 1 centimeter each, and place a video camera in the chest and perform the operation, which obviously has a better cosmetic result at the end and also leads to less postoperative pain. And this is just a quick example. I'm going to take those 2 extra minutes that Ed stole from me. This is an example of a peripheral carcinoid. We could do a sublobar resection. We plan to do this minimally invasive. Here we're just getting access for our cameras. You can see the tumor right there puckered. I will then look at all the blood vessels and start freeing them up. Here I'm removing the tumor to confirm the diagnosis. Once we confirm the diagnosis as a malignancy, we then can perform a sublobar anatomic resection called a segmentectomy. We get to play with these fancy devices. These are the individual blood vessels that we're going to separate, but we're separating them much further out in the lung, so we're saving lung tissue. And the benefit to this approach versus a non-anatomic wedge resection is that those black round things called lymph nodes that you see my clamp going right next to, right here next to that blood vessel, as my mentors told me at Memorial, the lymph nodes are lazy. They like to hang out by the blood vessels so they don't have to work. We're able to sample those those lymph nodes and make sure we get the most accurate staging and also control what we call the lymphovascular pedicle, meaning all the lymphatics and all the blood that's draining from the area of cancer are removed in continuity so that we make sure that there's the least chance of recurrence of disease. And so here we're just individually isolating blood vessels, and we use our special stapling devices to divide them. Likewise, this is the individual small airway to just 1/3 of the right lung, meaning we are isolating the blood vessel to the posterior segment of the right upper lobe, which is about 5% of the lung volume. So we're saving the vast majority of lung. And that's our stump, and you're going to see a little trick. We're going to blow up the lung and see where it wants to separate, and then we can just staple right across and complete our dissection. And then here we take the lymph nodes. As all the surgeons have mentioned, clearing all lymph nodes is critical, so this is also critical for staging. We check all of the main lymph nodes that we have available. Now, I also have a quick video for bronchoplastic surgery, if I can show that. I don't know if this is going to project. This is what an endobronchial carcinoid looks like. This is a patient. He was a semi-professional basketball player. His father is actually a professional boxer of world renown, who was having problems in training. He was going to go over to Italy to play for an Italian basketball team and was really short of breath, couldn't figure it out, was sent to me, and we saw all the telltale signs of a carcinoid tumor because his left upper lobe was completely collapsed, and he also had a lot of changes in his left lower lobe. And when we did the bronchoscopy, we see this centralized, what we call cherry red rounded tumor that's blocking the complete entry to the left upper lobe and almost the entire left lower lobe. But we're able to then pass our camera through and establish that there's no disease past that area. And for some reason, and then forgive me, I couldn't edit this video, so I'm just going to have to show it to you this way. Once we do the surgery, inside we can find that area where the airway is blocked, cut it out, and then you can see here we're simply just sewing the bottom airway back to the top. So the bottom airway is here. The cancer has been removed with the upper lung. This is the left main stem bronchus, and we simply just recreate that connection like plumbing. We remove the blockage, take out only the lung that needs to come out. We save that entire lower lobe, which is 25% of the lung volume. He can go on and pursue his professional basketball career. And then I will show you what that looks like at the end. And here's the bronchoscopy done at the end of the operation. And as we go down, you can see here's the cartilage from the lower lobe connected now to the main stem bronchus, and here's the superior segmental airway to the left lower lobe, and then the rest of the left lower lobe airways here. And you can see this one special stitch sitting right in the middle, and this is why you have to go to people who know what they're doing, because when you reconnect these airways, the tendency is to kink the smaller airways when you do these reconnections because the anatomy isn't perfect, and you have to know how to do a tracheopexy and pull that airway out and support it so it doesn't block itself so that you don't have collapsed lung distally, and that's what that one extra stitch will do. And we perform that by having a video camera in the airway while we put that stitch to make sure we're pulling it out. So we are very fortunate here. I thank you for your time. It's really a great honor. I'm happy to take questions during the panel. So I hope we achieved our goals, which was a basic understanding of lung neuroendocrine tumors, what the role of surgery is, and hopefully, most importantly, alleviate a lot of concerns and fear about the diagnosis of a pulmonary carcinoid tumor. So thank you.